Welcome back to day 2 of the PTLI Disruptive Innovation Summit. Hoping everyone had a chance to rest and reflect on our stimulating plenary session. We are very excited to continue our discussion today about the application of the learning sciences and physical therapy education. Before we get started, we do want to thank our sponsors, Rehab Essentials, again, for their generous support of this event. And to maximize our time, we're going to jump right in. I'm going to turn the program over to Mary Blackington and Laurel Abrazazi, who will be facilitating session 1, which will focus on application of the learning sciences to physical therapy education. So take it away, Mary.
Okay, great. Thank you, Karen. And you're going to share the screen again if you want to do that to start, when I start introducing the speakers, if that's
Okay.
just to have all their names front and center. So thank you all. Welcome back. Thanks for coming to day 2. We're really excited about it. And I'm really pleased to present the first session. So our first topic is the application of the learning sciences to PT education, and it's relevant really to all physical therapy education and practice. Our session 1 speakers represent a variety of institutions, from R1 public institutions to a private not-for-profit faith-based institutions. And our presenters represent entry-level through post-professional residency education and work in institutions with diverse curricular models, including residential, flipped, hybrid, and one with a competency and entrustment framework. And so the order of operations is there are actually 4 speakers in this first session. I'm going to introduce all 4 of them now, and then each of the speakers are going to share their screen. And when they're done, they'll stop sharing and the next speaker will start. When we're done with all 4 speakers, then we'll come back together. We'll give you some directions before going out to breakout groups. So again, the full biography of all of our speakers that you see in front of you today is on the PTLI website under the Disruptive Innovation Summit. And I'm really pleased to announce that we begin with Adam Persky. Adam is Professor and Associate Dean of Professional Education at the University of North Carolina School of Pharmacy. He sets the stage for us this morning by discussing evidence-based teaching and learning strategies applicable to the classroom and clinical practice. And it's a very logical continuation from the presentation by Nikki and Maria yesterday. His session is slightly longer because he's going to set the groundwork with the evidence that's available. He's then followed by our 3 Ignite speakers, and they include Susannah Steele, who's Assistant Professor and soon to be Assistant Program Director from Concordia University at Ann Arbor. Next, we'll have Priscilla Weaver, Clinical Professor and Director of Educational Transformation at Northern Arizona University. And last but not least, we'll have Kevin Wong, Professor of Rehabilitation and Regenerative Medicine at Columbia University. Kevin represents the application of the learning sciences in post-professional education in his role as a residency director. So without further ado, Karen, I'm going to have you stop sharing, and it is my extreme privilege to announce and bring center stage Adam Persky.
Well, thank you for the invitation to come talk to everybody today. It's always great to see other schools and other disciplines. And I can safely say that whatever troubles or issues you are having in your curriculum, whether it's didactic or experiential or clinical or postgraduate training, we're all having the same problems. I go to lots of places to talk to people and we all kind of struggle together. So hopefully this summit's a great way to bring people together, find resources that might be helpful to you. So if there's anything I can do in the future, you have my contact information on the screen. Please feel free to reach out. I can always happy to give my 2 cents. And just a small side note, I see someone named Phil wearing a University of Miami Hurricanes shirt. My wife went there. She's a very proud alum. I'm a Gator by, PhD training, so there is some conflict there, but I will make sure she knows that there's a Canes fan inside the audience today. So my job today is twofold. One, to talk about how we learn. And I like talking about how we learn from a cognitive science perspective because it makes it easier to make decisions about what we should do in the classroom or experiential space to troubleshoot what we're doing versus just simply adopting active learning strategies for the sake of active learning strategies. And the second part, kind of already mentioned, is to help set up the other speakers as far as how what they're doing is evidence-based and fits into the model of how we learn. So let me start with the first part of when we talk about learning, what do we mean? So we're all on the same page. So I like using the definition to the left here that the ability to acquire new information, skills, and retrieve that information when needed to apply to a future problem. So it involves both learning and retrieving. Two big parts of it is retention, that we're going to learn something and hopefully we keep that stuff in memory for long periods of time. We're dealing with professional programs, health sciences. So what we learn day one in the foundational classes, we need to remember when we're dealing with patient care 3, 4, 5 years down the road. Very different than maybe some of the undergraduate models. Retention is hard. Getting students to remember things is hard. The transfer part, that is using what we learn in one context in a slightly different context. What we might learn about a modality in a young adult patient, how does that transfer to what we might do in a geriatric patient? A much harder ask for the learner. So when we talk about learning, we're talking about all these things. So how do we learn? And this is going to be a 10,000-foot view to kind of frame the rest of the 20 minutes. So in most circumstances, there's someone you see on the left here that is speaking, that has visuals. So like right now you see slides in front of you, you hear my voice. So in the classroom, it's very much like this. In a clinical setting, it's your preceptor, it is the patient that you're hearing. There are things you can see. Now there's lots of things in our environment to pay attention to. Now, if we pay attention to something in our environment, then that's one of our first key places for interventions, that there's things we can do to help direct our learners' attention and motivation. And I would say this is probably one of the hardest things that we have to do as instructors, as preceptors, is to help this attention and motivation. So what do I mean by attention? Attention is kind of the spotlight that you are focusing on. So right now, hopefully your attention is on me and the content and the stuff on the screen. If the phone was to ring, your attention would probably go to that phone. Now, the next step is, well, what do you do once your attention is broken? And that really comes back to motivation. Is your motivation to answer the phone, or is your motivation to go back to listen to me talk? So again, we're always kind of making these choices of what we're being attentive to and what we're going to dedicate our motivation to. But again, this is a place for us to be to intervene. Once we pay attention to something, it goes into what's called working memory, which is a small space in our, it has a finite capacity. It can only hold things in a very temporary storage place. I'm a baker on the side, well, more for fun. And I equate it to my bench top, the place where I can mix ingredients, knead dough. I can only do so much there. If I want to do more work, I have to get that stuff out of my counter and put it somewhere else. So working memory is kind of like the counter space that you're working on. And we know that people with lower working memory capacity have more off-task thoughts. This is kind of the bottleneck in the system. If we overwhelm working memory capacity, there's only so many things we can do. So our goal is to take stuff from working memory, this kind of temporary storage place, and put it into long-term storage. And we can do it through what's called encoding and consolidation. So this is the other place we can put our efforts in, and probably where we put most of our efforts in when we do active learning, when we're doing all these, muddiest points or jigsaws or other things, we're kind of helping encoding and consolidation. So this is where we're really kind of trying to change brain structure, that when we start learning something, we have new dendritic growth, neuronal growth, making new connections. That's the encoding part. We're kind of starting those branches. Consolidation is when we're kind of reinforcing that neuronal growth so it stays there for longer periods of time. So we're learning something, we're putting it in working memory, it's going to long-term storage, hopefully, And the next part is, well, we have to get it out of long-term storage because we're going to use it to solve problems, going back to that definition. So how do we make information more accessible so we can use it when we need it? And we can build this kind of 2x2 grid here of storage strength. Is it stored well in memory or is it not stored well in memory? And how accessible is it when we need it? Is it highly accessible or not so accessible? So your ATM password, stored really well, really accessible. If I asked you for it, you can just blurt it out. Please don't. But it allows you, it kind of gives you an idea of like, what does knowledge really feel like? If we move to the right, high storage strength, something you learned really well, but low accessibility, low retrieval strength. Maybe something you learned in your childhood friend phone number. Example I often use is in my class, I sometimes give fill in the blank answers. And the question was, what is the breakdown product of red blood cells? And one of the students wrote, it's on the tip of my tongue. It's like a kid's name, Billy something, but I don't know the word. And that's exactly what we're talking about. They know it, it's tip of the tongue, but they can't access it. And the word is bilirubin. That's the breakdown product we're looking for. So kind of knows what it starts with, kind of knows a kid's name, but couldn't generate the word. So that's kind of that we call marginal knowledge, kind of that tip of the tongue sensation. Low storage strength, but high retrieval. What'd you have for dinner last night? Right now, you can tell me with some detail what you had for dinner. A week from now, you have no idea. So when students study the night before your exam, what they're doing is increasing retrieval strength, but not really helping storage strength. They can pass your exam and do well. It doesn't mean they're going to retain that information because what they did was really just make it very accessible without really learning it for long-term storage. And if it's not stored and not retrievable, you probably never learned it in the first place. For example, what my Twitter handle is. So this is kind of the basis of all the ways we can intervene to help learning. Now, the next 3 slides are a little bit more in depth for these 3 areas, and I don't have the time to go into detail, but you'll have the slides. You can look at them at your own leisure. But when we get to attention and motivation, there's lots of things we have to consider. Curiosity, relevancy. Our approach to students, we make a big difference in the classroom and in the clinic as how far students learn to it. But at the end of the day, what attention and motivation is trying to do is mind wandering, being off task doesn't help learning. So we want to help students and trainees be on task. And active learning and experiential learning helps these on task thoughts. That's really what we're trying to do with lots of the active learning part is keep people on task. When we get to encoding consolidation, again, lots of things, so many things, an overwhelming amount of things we could do. And the article that's cited on the left is from the journal Science, a pretty prestigious journal. It goes through this and say, hey, if you do these things, there's like 15 million combinations of things you can do. But I'm going to summarize it in 4 words. Elaboration. Help students elaborate on what they're doing, asking why. Why do we have ball and socket joints and why do we have hinge joints? Provide distinctiveness. We learn by differences. What's the difference between a ball and socket joint and a hinge joint as far as stability or motion? Make it personal. Why do I even need to know these joints? How does it impact me as a physical therapist? How might it impact me as a healthcare provider? And have it apply to real world problems that they actually will actually use it for. Why do I even need to know about these joints? How is it going to affect me? How am I going to apply it? So if we're teaching things that you simply have to memorize stuff with no application, it's much harder for them to know why they're learning it and harder for them to apply it and transfer those skills later on. And the third part, the retrieval and accessibility, having people retrieve stuff from memory, asking questions, using clickers. Again, lots of things we can do to help our students and our trainees retrieve information to make it accessible. Now, I'm going to try to preview some of the things that we talked about a little bit later and try to link to what I just talked about to what they might be talking about. So at the very level of educational practices, instructional alignment, to align our learning objectives with our assessments and our instructional delivery, you first start with the goals. Then you develop assessments to know students are making progress towards those goals and have achieved those goals. And then how do we help students coach them through this model? So learning goals are about motivation. Here's what I expect of you. Assessment is kind of about that retrieval part, also part of motivation, and instructional delivery is really about the encoding consolidation. It's about the retrieval part. So, but really foundational. It's not sexy. It's not innovative. It's just very foundational. And if you do this, you will see large effect improvements in your teaching. The alignment really helps you figure out what's important and what's not important. It helps communicate to the students what's important and not important as well. So something very simple can be very impactful as far as changing teaching practices. Now, we now have this thing called entrustable professional activities, or EPAs. It started in medicine. Pharmacies adopted them. Dentistry is slowly getting there. And now physical therapy is doing there. So it's kind of like a new version of a learning objective, but really it's for a workplace activity, where learning objectives are much more describe this muscle architecture. This is more what you expect to do in a workplace. So it's a task or responsibility that you're entrusted to perform at the end. So when you graduate, you're expected to do this as a fully functional physical therapist. It's executable, it's observable, and it's kind of a self-contained aspect of it. So it's really kind of translating what we do in the classroom to what we expect to happen in the workplace. So these EPAs are kind of the new version of what we expect to do in the workplace. So this is how we set the goals. How we assess them, also a little bit different. We kind of what's called make an entrustment decision. How trustworthy is this trainee? Really, at the end of the day, are you willing to walk out of the room, get coffee, and leave your trainee there to do the job you're set to do? If the answer is yes, then it's a high level of entrustment, low level of supervision. So it's about not only what they can do, but do you trust them? Are they good people? Do they know they have humility? Are they reliable? So it's much more than just like a knowledge-based assessment. So there's a whole continuum here of less entrustment to greater entrustment. If you're unwilling to leave this person unsupervised, what level of supervision do they need? Do you need to be over their shoulder watching every move, or can you step back and kind of observe and intervene when needed? So how much supervision? That's really what's get at the basis of entrustment decisions. And this approach is different a way of assessment. There's two big ways we can assess people. Holistic, you see the big picture, you observe what this person's doing, it's very holistic. Versus analytical, which is much more rubric driven. Here is, do they have the knowledge? Are they professional? Are they communicating? You're scoring each aspect of it. So depending on the skill, depending on the assessment, we can do it holistically or we can do it as a more analytical approach. And why is assessment important? One, it helps with accessibility. Two, it helps us and the learner gauge what they know and don't know. Imagine you never got feedback on what you were learning. You would never know whether you're right or wrong. So percent correct on the y-axis, predicted performance and actual performance on the x-axis. Predicted performance is, I'm going to give you a test. How well are you going to do on this test? If the instructor is fluent, you come in, you give a great lecture. You are a great lecturer. You know, you probably know who you are. And the students leave and they're like, man, that made so much sense. It was fantastic. They would say, I would get a 66 on this exam. Someone comes in who's not a great lecturer, maybe they don't communicate that well, they're not a great teacher, and the students leave like, that wasn't such a great thing. They make that prediction, they predict to get a 50. When you actually test them, they perform about the same. So sometimes making things easy, making things more fluent is deceptive to the learner. So they're overconfident. They're overconfident by almost 20 points. They thought they'd get a 66, they got a 48 because they thought it was easy. Compared to this fluent instructor, they're overconfident, but by a much smaller amount. So learning has to be hard. It's what we call desirable difficulty. It's hard, but be overcome with effort. So active learning, experiential learning is all ways to kind of make learning harder so students have a better idea of what it actually takes to do the task that's asked of them. And then we give feedback to them. You know, we can do it two ways. We can just tell them, hey, here's the feedback. Here's what you did right. Here's what you did wrong. It's accurate. It's very efficient. And we feel good about ourselves. We're like, hey, we gave them feedback, good for us. The downside is, well, the learner may not process it very deeply. They're like, oh, whatever. They may not be very attentive to it. It may not engage in long-term memory, and it kind of steals their chance to shine. Conversely, we can have them generate their own feedback. It forces them to give attention to what they did. It engages their long-term memory, gives them that thrill of success. The downside is, well, they might be wrong, or they might be frustrated or flounder when trying to figure out what I did right or what I did wrong, and they might fail at it. So how do we do this in maybe a more reasonable way? Well, we can combine the two. What do you feel went well, the self-discovery part? And here's what I saw. So this works really well in the clinical setting where there's more one-on-one sorts of interactions. So again, kind of mixing the two feedback mechanisms to really make sure that learners are leaving with a better sense of what to do next time. And if we want to give feedback on critical thinking, so there's 3 aspects of critical thinking: the attitude or disposition to think critically, the knowledge to actually use critical thinking, and then the actual thinking process. So if someone gets the wrong answer, it's because, well, did they actually engage that system to think critically, or they just went with their gut reaction? Were they missing knowledge that, hey, you got the wrong decision because you're missing this key piece of information about the patient? Or were they wrong because they didn't go through the correct process? They didn't weigh the evidence correctly. So again, just a preview of critical thinking and how we might intervene as far as a feedback mechanism. And then you heard the word competency-based education. It's not a new thing. It's not a new term. It's been around for a very long time. It's really about focusing on helping students become competent on the outcomes. Everybody's there to learn. So how do we help all students achieve the learning objectives of our courses in our curriculum? We want to do it in a way that supports the students, that we're using active learning, and we want it to be as authentic as possible, to making sure they're doing real tasks to understand what really is special about this application part. The big thing about competency-based education, which makes it so hard, is the 3rd bullet point of time. We all learn at different speeds. Some of us passed our driving test on the first time. Some of us passed our driving test on 3 tries. It doesn't mean we're bad drivers if we take 3 times to pass it. It just means it took us longer to figure things out. So competency-based education is about removing this time element, which is probably the hardest thing for us to do because we have 3 or 4 years to graduate a student. How do we build this time variability into our curriculum and our courses? And then we have the experiential learning part. We all know experiential learning leads to much better results. So number of correct answers on the y-axis, weeks after learning on the x. Lecture, we can leave class and we forget things pretty quickly. Experiential, we tend to remember things. It's much more emotional. The seeing the patients, the doing, the smells, does a lot of things to reinforce learning. So we like experiential learning, which is why a lot of our professional programs have key parts of experiential learning, why postgraduate training becomes more important because it kind of accelerates that learning. So lots of key things. And what we're doing with active learning is trying to bring that experiential learning into the classroom. And for the classroom, we kind of use Kolb's model for experiential learning. So it's kind of like we're going to try some things, we're going to make some predictions. It's this cyclical thing. Again, what we're doing in the clinical setting on a one-on-one basis for learning, we're trying to bring in the classroom when we have 50, 60, 100, 300 students that we're trying to get to engage in the material. So to summarize, understanding how we learn helps us solve problems better, helps us make better decisions about teaching and learning. The goal is to keep students on task and practicing what they need to practice. And that this assessment is the most valuable part to the students because that's where the grade comes from. So your assessments really show them what you value. So making them authentic or helping them really do the tasks that they need to do. And there's a lot of way to accomplish their goals. I can't come here and say, if you did X, Y, and Z, you would have great results because it's dependent on the students, dependent on you, and dependent on your curriculum. And I knew I threw a lot at you, but I had 20 minutes to do it. So at least hopefully some food for thought and maybe setting up the other instructors the other speakers kind of talk about how they implement some of these things. So thank you again. And whatever I can do in the future, please let me know.
Bear with me just a minute here. Get my slides up. All right. Can everybody hear me okay? All right, my name is Susie Steele. I am a faculty member at Concordia University in Ann Arbor, Michigan. And I'm going to take a very quick few minutes just to give you a few examples of how some of the learning principles that Dr. Persky was just talking about, what that might look like in entry-level DPT education. So before I jump into those examples, I want to just give you a little context about our program so you know where we're coming from. We run a full-time year-round program. It spans over 7 semesters. So we run on a 16-week semester schedule. Each semester is split into 2 8-week terms. So our learners are turning over new courses, 3 to 4 new courses every 8 weeks. So it is a very accelerated program by which they're learning. And so it really, because of that acceleration, is imperative that we engage our learners early and we engage them fully. And so we have a lot of mechanisms by which we can do that. I don't have time to go into kind of all of those today, but I want to just highlight a couple. So our blended program, we rely heavily on the flipped classroom model. So our students do a lot of their passive learning, their asynchronous content before they come into our class. And once they come into class, we're face to face with them. That's our opportunity then to really dive into that experiential learning. And so our program partners with Rehab Essentials. Rehab Essentials is key in providing a lot of that asynchronous content for our students. And then that really allows our faculty to focus in on developing really impactful educational activities within the classroom to really bring that content to light. The second point I want to make is we have a strong commitment to the master adaptive learner model, and we're very explicit about that with our students when they come in. I think it's important for them to know that ahead of time, because in order to get to that, approaching that level of adaptive expertise, they really have to understand why we're putting them in situations that may feel uncomfortable or may feel frustrating to them. And so and the point being, we want them to push their learning and to give them those deep experiences so that when they're in those unknown situations as a practitioner, they're going to be better equipped to navigate those successfully. So those are kind of 2 of the areas we really lean into. So the activities I'm going to talk about today, I'm going to try to get through 4 of these. These were all completed by first-year PT students in their first semester. So the very first one I want to highlight for you is when they were learning how to do a patient history. So this was in week 9 of our first semester. So a first week of a new course for them. The learners told me they felt like this was really the very first like real PT thing that they were getting to do. So their attention was high, their motivation was really high. It was a new task for them and they were really excited about it. And then to kind of up the ante a little bit, we brought in a person from the community to serve as the patient for our students, which really just made it much more authentic for them. And so what we did there, pre-work included watching videos and doing readings to understand what a patient history was. And then we started our class with just a quick Q&A just to clear up any points that they needed to have clarified before they did the activity, just so we all had a shared understanding of what a patient history was. So what they did when we came into the classroom, I created this shared Google Doc for all of us. And what it was, I gave them basically the categories for a patient history. And the students were then put into pairs. Each pair was basically responsible for coming up with what they were going to ask the patient, what that would look like. And then they had to document on this shared Google form what their answers from the patient were. And so each of them had an opportunity to do a little piece of a patient history. And what this did, we had this up on a monitor. You can kind of see a little bit in that picture on the top, where all the other learners in an adjacent classroom could see what was happening and what was being documented. And then they could make adjustments before they went in to speak with the patient. And so what it did, it created this very authentic experience for our students. And that's what really cemented it, I think, for them, right? So after all the students had an opportunity to go, then we debriefed as a large group and we talked about the experience. We gave the pats on the backs, right? Because this was like their first real successful PT thing they got to do. And we had some feedback from the patient as well, which was real meaningful to the students. The second activity focused on teaching principles. So we spend a fair amount of time in our program teaching our students how to be good educators. And so for this particular activity, they did some pre-work with videos and reading, just understanding kind of basic learning theory or reviewing basic learning theory, and then some basic considerations for what we need to think about when we're going to design a education experience. So they did the pre-work. We came into the classroom. Oftentimes I'll do like a large group Mentimeter quiz. It's all anonymous, but it just allows me to know, yes, they did the pre-work. They have an adequate amount of knowledge that they're going to be able to engage in the activity. And so again, in this case, they knew their stuff. And so we went forward with the activity. So another shared Google Doc. I promise I do other things too, other than shared Google Docs. So this one, basically what I gave to the students, I gave them a real life type of task. So Dr. Persky was talking about application and real life situations, right? So this was that way for them to start putting that knowledge into work. And then I also gave them the headings at the top of things that they needed to think about in order to teach a group. So the students were put into small groups of like 3 or 4 students, and they were assigned one of these situations in which teaching had to occur. And so the student's task was to go through the Google Doc and fill in all the boxes. What were their learners? What was the audience characteristics? What were they trying to teach them? What are some learning activities that might be effective? How are they going to assess their learners? So thinking about all of those things we have to think about before we teach. And so once they filled all that in, we shared out to the larger group and just kind of shared their experience and what they learned. And this was really powerful in that it was one of those activities that they made connections that I never could have taught them myself, right? Or reading could have taught them. So it was one of those activities where if I just kind of got out of the way and let the learning happen, it really was a unique experience for them. One of the groups commented, they had little kids and they needed maybe a lot of activities in order to keep their attention. Another group commented that, their activity was real specific to an environment. So they needed to think more about the environment. So again, I'm not super concerned if their answers are that accurate, but what I want them to learn is what do I need to think about to be an effective educator? And I think they did that here. So fast forward about 4 more weeks, we got to an end of semester assignment. So this is like week 16 of the first semester. Still on that content of learning principles, teaching principles, excuse me. They were in groups of 3 and they had to identify essentially a community of learners, and then they had to figure out something to teach those group of learners. They had to develop a learning activity, they had to develop objectives, and then they had to assess their learners. And once they completed all of that, then they came back and presented to the group about that experience and how it went for them. So there was action, right? They were applying the principles that they learned, but then they also were reflecting upon that experience too, to kind of make that learning go to a deeper level. So these are just some examples from our student presentations. We had one group, they took some high school runners in the area and taught them sprinting mechanics. We had another group who they took some faculty and wanted to teach an exercise program for stress management, and that was their assessment piece there. So they had fun with it, right? But at the core of it, we got to the objective of they had to be teachers, and they had to, go through those steps of what it means and put that an effective educational experience together. So again, they learned a lot from the application of it, and we're really able to kind of now have a lived experience from which they can grow. The last one I want to share with you. So this was done in about week 12 of our first semester. Our learners were in a course where they were learning how to assess multiple dimensions of health in people. And one of those dimensions was doing basically a comprehensive fitness profile. And so we had a shout out to Dr. Jen Gamboa, who provided this amazing fitness profile assessment to me that I was able to share and use with my students. And so they previewed the instrument, familiarized themselves with that before they came to class. Then when we came into class, I had set up stations with instructions and materials so that they each could go through and complete all of the assessments and learn about those assessments. And they were basically filling in the data for themselves. And so then after class, what we had them do was this reflective assignment, 2 to 3 pages, where they had to reflect on what they did, what they learned, what it felt like. So trying to pull in a little bit of that emotional piece. And how they might apply that going out into the, treating patients into the clinic. So these are just some excerpts from some of those papers. So these couple writers here, they leaned a little bit more into making connections with other content we had discussed. So the top writer, he commented on how this aligned with the biopsychosocial model of healthcare and kind of pulling those pieces together that we had talked about previously with this activity. The bottom writer there, he took a little bit more specific approach and was recognizing, you know, if I do these tests, it's going to give me good information where I can make some really specific goals. So he worked more along that patient client management model, and was tying it to different aspects of patient care. And then a couple others, they kind of went along the lines more of a personal perspective, personal reflection on this activity. And so the writer on the top was talking about, you know, how some of this information can be a little difficult. It can be sensitive. And going through this experience, she really felt that firsthand and what that might feel like. And so it was a very powerful experience for her, and that she was now able to kind of develop that empathy for patients and really think deeply about, you know, what does that feel like to share that information or receive that information, and how might I do that in a supportive way for our patients. The bottom writer there, it was an interesting comment. They thought this was going to be easy, and it wasn't easy. And so I think it just speaks again to experiential learning really gives the learner a sense of, you know, perception of what we think is going to happen and what really happens is very different sometimes. And so having that experience and being able to recognize that what we think is maybe easy for patients may not be the case. So those are just a few of the activities that we did with some of our first year learners in the first semester. I thought it was really interesting as I was putting this together too. So, and I didn't tell our learners what I was asking them this question for, but I asked them, you know, what's one word that you would use to describe our curriculum? And these are some of the answers that they provided to me, right? So I think it really speaks to that idea of experiential learning, right? It can be difficult for our learners. It can be a challenge for our learners. It's unique, and that is often not something that they have gone through to the extent that we're putting them through that at this stage of their learning. But I think they recognize how applicable it is, how collaborative it is, and it really, some of the change we have seen in the students over just that first semester has been really quite amazing. So I think, you know, speaks to the fact we're leaning into that applied learning, and they're benefiting from that. They're from that experience. So thank you.
Okay, just a thumbs up, Mary, that you can see my screen. Perfect, thank you. All right, so I am here to ignite the academic and clinical community to embrace competency and entrustment-based DPT education. As quoted by Stephen Covey, to begin with the end in mind means to start with a clear understanding of your destination. It means to know where you're going so that you better understand where you are now, and so that the steps you take are always in the right direction. When applied to DPT education, the end in mind is a graduate physical therapist on their first day of clinical practice delivering safe and effective care to a patient unsupervised, still recognizing the importance of mentorship and lifelong learning. A competency and entrustment-based education framework has a clear understanding of the destination through the outcomes of competencies and entrustable professional activities, or EPAs. The competencies being the knowledge, the skills, attitudes, and values required of a physical therapist for clinical practice. The EPAs being the essential clinical activities or tasks entrusted to the learner by graduation to execute unsupervised on day one. The EPAs draw the connection between the learner's abilities or competencies to these essential tasks or work activities. For example, an EPA could be gathering a history. To carry out this EPA, a learner should possess the abilities such as active listening, communicating, critical thinking, and managing time. Displayed is Northern Arizona University's competency and entrustment-based education framework for our hybrid and residential DPT programs. To the right side, you will visualize the outcomes of competencies, and to the left side, the outcomes of EPAs. Centered are the domains of competence, which are the broad competency areas that represent the PT profession and aspects of the university mission. Starting on the right side, the competencies fall out of the domains of competence and are scaffolded each semester within the courses as course learning outcomes. The milestones of competence are the benchmarks of the progression of competence and the readiness of each learner for clinical education and practice. We will return to the left side in a few slides. Visual of the intentional placement of our 3 milestones of competence. Again, these are the benchmarks to measure progression in the competencies and readiness for clinical education or practice. The first milestone is placed prior to a first full-time clinical experience and represents, through assessment, the learner's achievement of a threshold of competence to progress to clinical education to carry out the EPAs with a specified level of supervision. The second milestone is placed prior to our terminal clinical experiences and represents a higher threshold of competence to progress to clinical education to carry out the EPAs with increasing autonomy. Lastly, the final milestone of competence represents an achievement of the established competencies for the curriculum and readiness for clinical practice post-graduation. Now we are going to move to the left side of the framework relating to the EPAs in the gray bubbles. As a reminder, the EPAs draw the connection between the learner's abilities to the work activities of a physical therapist. The EPAs and competencies are matrixed together to outline the critical competencies from the right side that the learner must apply and integrate to carry out an EPA in clinical practice with increasing autonomy. For the example EPA of gathering a history, some of the critical competencies may be the learner's ability to provide person-centered care, utilize motivational interview strategies, or demonstrate active listening. These are some of the abilities the learner must possess to gather a history. And now to the very left side of the screen, the assessment of EPA shifts to levels of entrustment and supervision for carrying out the EPAs while on clinical education. Let's talk further about the entrustment decisions. Entrustment decisions are the decisions to entrust a learner with an EPA. It's assigning the responsibility of something valued or important to another person. These entrustment decisions can be made ad hoc or summatively. Both types of decisions are based around qualities that enable trust in the learner, similar to what Dr. Persky was talking about, such as being reliable, truthful, recognizing limits, asking for help, and being able to receive that feedback. The ad hoc entrustment decisions occur daily by the clinical instructor for the learner to practice EPAs at a specified level of supervision, depending on the patient and many other factors in the environment. The summative entrustment decision does not occur daily, but are decisions that occur at specific times in the curriculum, such as at the end of a full-time clinical experience and the end of the curriculum. A summative decision is making a decision of the specified level of supervision for each EPA going forward to the next clinical or to future practice after graduation. It is a decision that evaluates all the ad hoc data that has been collected over the course of clinical experiences and ultimately over the course of the learner's time in the program. A clinical competency committee within the academic program makes the summative entrustment decisions informed by the systematic observations of the clinical instructor and other information gathered through a variety of sources. Prior to graduation, the final summative entrustment decision is made for each EPA and signified responsibility of the learner after graduation and licensure to safely and effectively carry out each EPA unsupervised on day 1. Represented here is a 5-level scale of entrustment and supervision for use in clinical education for each EPA that represents a scaling of trust and autonomy. When we are thinking of ad hoc entrustment decisions that happen daily, the CI is having the learner practice within these levels and rating the learner frequently versus the summative entrustment decision that occurs at the end of the clinical experience by the clinical competency committee and is a permission to act at a specified level for the next clinical or for future practice. Let's go over this scale. Level 1, the learner may be present but may not practice the EPA. The learner is observing the CI gather the history, for instance. Level 2, the learner may practice the EPA under direct proactive supervision with the CI physically present. It could be a co-activity with the CI, or the CI is ready to step in to assist if needed when the learner is gathering a history, for example. Level 3, the learner may practice the EPA under indirect reactive supervision with the CI not physically present next to the learner, but maybe outside the room listening, or across the gym, and is quickly available and provides feedback afterwards versus during the encounter. Level 4 is where we want the CI to have the learners practicing, especially on a terminal clinical experience. The learner is practicing as if they are unsupervised, recognizing the CI is still providing that legal oversight. However, the learner is demonstrating their ability to practice unsupervised for after graduation. Level 4 is the entry-level expectation for the final summative entrustment decision at the end of the DPT curriculum. Level 5 is a post-professional level of supervising others to carry out an EPA, such as a DPT learner on clinical education or mentoring another PT. The learner can practice these roles as a student, but there would not be the expectation to meet this level in DPT education. We began with the end in mind. We have returned to this graduate physical therapist on her first day of clinical practice, where she is delivering safe and effective care to a patient unsupervised. In a competency and entrustment-based education framework, progressive competence of the competencies and autonomy of the EPAs have allowed the graduate a clear destination to climb up Miller's pyramid with the addition of trust at the top, representing not only performance, but also entrustment to carry out the essential responsibilities of a physical therapist. So let me ask you, are you ready to embrace a competency and entrustment-based framework in your program? And here are my references. Thank you for your time.
Hi, everybody. Greetings. A couple other things about myself and my bio that might be relevant is, first of all, I spent my 30-something year career straddling both clinical care and academia. Currently, I run the clinical residency program, and I've designed two actually clinical residency programs of different designs that were both APTA certified. So that's to say I'm pretty comfortable with what advanced practice is, but I've also been a CAPTE on-site accreditor, so I'm very comfortable with the concept of what entry level is. First of all, what is advanced care? And one of the things about entry level that's already been discussed is, the person should be autonomous, they should be safe, you should use evidence, but sometimes you're going to need supervision for complex scenarios. And complex scenarios are often difficult because they might be unusual, uncommon, unresearched, or heterogeneous. Advanced level of practice is all those things consistently, but is also adaptable and effective in situations that might be complex or conflicting. So for instance, that could be multiple different problems interacting. Just from my own current clinical caseload, people with head injury who also have arthritis, people who have Parkinson's but also have radiculopathy, people who have cancer but also have spinal stenosis. But that could also mean interventions that are difficult to show their efficacy within the research, or to do in a complex scenario. For instance, a L5 muscle energy technique involves using hip internal rotation as a lever, but that becomes very difficult to do when you have a transfemoral amputee who has no tibia in order to grasp. And then sometimes the evidence conflicts. So for instance, a anterior to posterior shoulder mobilization is more effective in producing external rotation in people with frozen shoulders than posterior to anterior, which would be more consistent with the concave convex rule. So, and then of course, expert level is all of those things, but also be able to innovate new techniques. Now, in preparing getting our residents' attention, first you have to prepare the learner to learn. And so part of that is knowing your audience. I always consider that number one. And that might mean knowing the person's biases. Judging from my social media feed, some of the things that might be common would be evidence as medicine, or randomized control trials as the foundation for evidence-based practice, or maybe manual therapy doesn't do anything at all. So these would be some things that people might be coming into class with. We do an activity called Deconstruct a Dogma, which is really like a journal club where we deconstruct some of the assumptions that have been made and carry on in physical therapy, even though they've been discredited over 30 years of research. So for instance, that might be McConnell taping for VMO activation, or scapular dyskinesia as connected to pain and disability of the shoulder. But ultimately, a journal club is really just talk. And even though for all the clinical scenarios that I'm mentioning, I have references in case someone gets individually curious. So although we have research to back these ideas up, really it's just talk, and talk is cheap. So we do another activity called Resident as.
Bob saying something was, he came by our house and there was something on that he did not describe.
Excuse me, could you mute, please?
Sitting on the back porch, I said a snake.
Excuse me, could you mute, please? Thank you. So we do another activity, experiential learning activity called Resident as Subject. That could be, for instance, identifying an impairment on a resident and then asking them to choose a technique to try to overcome that, letting them do that, seeing how they failed, and then showing them another technique that they're about to learn, and then following up in subsequent weeks to show that not only did it work in the moment, but that it worked and maintained its gain week after week after week. Now, I just mentioned randomized control trials and evidence-based practice, and a lot of times in evidence-based practice, we hold the randomized control trial as the pinnacle of the evidence. However, randomized control trials ideally use homogeneous samples, therefore don't include unusual or uncommon cases. And then we have to ideally use a standardized treatment approach, but a standardized treatment approach does not account for individual needs. And then the RCT reports a group average, which excludes the outliers. So you can see how a randomized control trial, as I always say to people, subjects are not the same things as your actual patients. And so we think, there's something better? And so what we teach is something called research-based practice. And how we get there is we use a technique called research-based learning. And so in research-based practice or research-based learning, it's perfect for your cases that are unusual or uncommon, but also really for everybody, because not everybody responds in the way that is anticipated. So this could be something as simple as, at its most basic, reliability testing. We can test between one resident and another, or a resident and a faculty. So that would be inter-rater reliability. We can test intra-rater reliability from 1 week to the next week to the next month. That would be one very simple way. Or we could use some quasi experimental techniques like testing and retesting. Testing retesting is good, but again, quasi-experimental. Better to do, say, time series design, whether you have at least 2 assessments on each side, or even better, borrowing from N=1 research methodology, we would have pre-phase and post-phase. So that would include at least 3 measures. And that's an experimental design that can establish cause and effect conclusions. So that would be a better way to do it. And how this might work out in a classroom or in the clinic can be as simple as treating one person and then, treating like one person and then waiting to start the other person. Say if there is a waiting list, you could go work on the left side on Monday and then work on the right side on Wednesday. Or we could break it down into planes. We can work on shoulder flexion today. We can work on shoulder abduction the next week, or really within different angles of each plane. So we could work at 90 degrees, which is not the same thing as 145. Or we could work on comparing different conditions, for instance, different treatments. We could use exercise versus manual therapy, or honestly, you can do an exercise dose of one sort versus an exercise dose of another sort to get a comparison of what is working and what is not working. For those of you who might have ethical concerns about this kind of approach in clinical practice, just bear in mind, there's zero chance that any patient can have all of the impairments and functional limitations treated in one single day. So really, this is just a thoughtful, planned out, intentional ordering of your treatments, and then with assessment and reassessment, hopefully multiple times, to establish a really sound research methodology to practice, but also in the clinic. And I know my portion of this is really about post-professional training, but you should know we apply the same techniques in entry-level training. So these are just some suggestions that you could use. The proof, though, is ultimately in the pudding. In the lab, we assess our residents' success within the session, and they also write a reflection about how they use this approach in the clinic and with clinical mentoring. But the ultimate is showing how they can apply this approach to unusual, uncommon, unheard of, unresearched cases, trigeminal neuralgia, most recently, a cremaster strain, even neuralgia paresthetica, not commonly in the evidence base, to show whether that could actually occur, because that is overall the point, is can we make patients better? All the teaching that we do should be aimed at that goal. So the basic takeaways: why should you attempt to use research-based teaching and learning into leading to research-based practice? Is number one, it is very engaging and motivating for students, residents, or patients. Also, it allows us to teach and practice in areas where there is without solid evidence. My primary research area is amputations, and it's a very heterogeneous population. Spinal cord, same way. Pediatrics, same way. And then finally, we emphasize scientific thinking in problem solving by having them use the scientific method so that they're able to solve problems in the clinic long into the future. Thank you so much.